information on fetal cardiac function and hopefully teach us everything that we need to know to assess heart function in the baby. Are you there, Josh?
I'm there, but Helena, you got to tone down that Texas accent.
That's right. I'm indiscernible, aren't I, from a true American?
So I think we're ready to start the scan. And we have a 23-week fetus here that a moment ago was in what we call the patriotic position for scanning in the United States. That is, the arms were right across the heart, as if pledging allegiance to the flag. And we've still got, now it's the left arm across the chest, but I think we'll be able to get around this. And there were a few things that I wanted to look at. We're supposed to be talking about cardiac function, so I thought I would start with some functional measurements that we take, and then try to take any questions that people have from the audience, if that's okay. In the session, the cardiac session yesterday, people were talking about what different Doppler assessments they do. We try to do some comprehensive but brief Doppler on every patient who comes for a fetal echo, and we start by assessing the flow across the AV valves. You're going to have, please bear with me as I scan here, because this is my, I just met this ultrasound machine yesterday, and the controls are a little different than the previous generation, but we'll get everything here. I'm going to first zoom up on the heart. Yeah. There we go. Zoom up on the heart. And just for orientation, we have the spine back here. So I'm seeing descending aorta and the left side of the heart, the right side of the heart. We've got nice motion of the tricuspid valve, and there's the mitral valve. I think we can also appreciate the slight difference in position of the two valves on the interventricular septum. I'm going to take the spectral Doppler sample volume and place it just above or below, depending on how we're looking at it, the tricuspid valve. Just going to adjust this a little bit to get the scale. Now I got to adjust my position because the baby obviously moved while I was doing that, but as I go through this with fellows, I keep telling them perfect is the enemy of the good, so get as close as you can and then tweak it. Don't worry about having everything perfect from the beginning. All right, so this is flow into the right ventricle, and I'm going to bring up the calculations package for inflow into the right side, and we can measure the, let's see, right here we can measure the peak of the passive filling and then the active phase, and we see a typical ratio, E to A ratio there in the fetus, and that just moved a little bit after I let go. There we go. So that would be a typical mid-trimester E to A ratio for the right side of the heart. Go back and readjust. I hope it's reassuring for the audience to see that even people who are asked to do these scans get babies in bad positions and moving around. So we're going into the left ventricle. I'm going to move the baseline up now and change my scale a little bit. Yeah, and the baby moved again. I'm trying to tweak it just to get into a spot where I'm going to see a lot of different information. Okay, so here we've got a lot of information, at least in the Doppler. This is the inflow and outflow of the left ventricle. So we're in the left ventricle there. This is filling and emptying. Not quite the way I want it for the emptying. We'll come back to that in a second. First, we'll take a measurement. So again, what we do typically on our fetal echoes is measure the E to A ratio. So I'll take that measurement. Again, a typical appearance. in the left ventricle. Now, the other measurement that we'll often do is what's called the mechanical PR interval, and we use it for fetuses at risk of congenital heart block. And I've got one waveform here that works for that. So what I'm going to do, actually first, let me erase the other, how do I get me to erase everything? Erase, all right. So erase all the other measurements because I think that'll come up with a better caliper. Yes, I like using the plus caliper for this. And I'm going to put the first plus right at the beginning of the A wave. So we see the E wave dropping down and the A wave starting up there. And I just go right into the bottom of the V. And I want the caliper to be placed where that V is, because the vertical line is going to disappear. If you set this just with the vertical line, then you kind of lose track of exactly where you're measuring. And then I'm going to hit toggle and move this down now so the caliper is right at the start of ventricular ejection. The angle on the ventricular ejection is not as favorable as the inflow. That's why the peak isn't as high. We're getting right about there. I don't think this is measuring right. Let's do it again. Let's go back into our acquisition. Sorry? Yeah. That's good. Sometimes it helps to make the sample volume a little bigger to do this, so I just increase the sample volume size. I'm trying to get around that arm still. Myself a little more gain. No. All right, let's go back, unzoom, and see if we can find a better window. Maybe it'll work right there. I'll zoom it up over here. All right. Now the fetus actually moved to help us out. We can see the ventricular ejection a lot better now. And I'm going to go to measure, and which I'm going to use the tools. And this should be measuring the same thing. So here's one where I can measure right at the start of the A wave and toggle it, and I'm going to go to the beginning of ventricular ejection. We see now we've got a nice measurement of 132 milliseconds, which would be a normal mechanical P to R interval. And notice as I toggle back and forth, or actually, no, they went away. The reason that I don't want to just rely on the vertical line, I want to leave the plus markers, is once we lose that, when we're storing the image, I want to be able to look back on a stored image and say, yes, that caliper is in the right place. If I do it, let me do it differently on the next one. If I just say, okay, I like the vertical line there, and that's pretty good for the vertical line there, then when I remove it, I can't really tell what I've been measuring. So think about that if you're measuring mechanical PR intervals. We do that for, as I said, for fetuses at risk of congenital heart block. Let me get out again and get reoriented. We also, in our regular scans, will grab some other Doppler flow. We like to look at the flow in the outflows, which the fetus is in a not so great position for, but eventually we find everything. Be able to get the aorta there. So we can see the aortic root is going directly away from us right there. And I'm going to make the sample volume smaller again. It was going away right there. There we go. I can do that better. Helena, do you do these routinely in your scans while I'm struggling?
Yes, I do. I do all flows through the valves routinely, but I don't do any screening scans. They are for abnormality, and I think that's important. I suspect that for most people, they wouldn't use pulse Doppler in a screening examination if on eyeball the heart looked normal.
Oh, I agree, absolutely. This is for our fetal echoes.
Yes.
All right, so there's a nice signal in the ascending aorta, and we would end up measuring the peak velocity, which we see right there. Nice normal velocity for the second trimester. And getting the pulmonary artery is going to be a little tougher in this position because it's not as good an angle. And I don't know if I can sneak past the baby's right shoulder. That's not going to give me the angle.
I think one of the difficulties with interpreting Doppler velocity waveforms in the fetal heart, just while Josh is getting the pulmonary artery there, is that if you have an obstruction to flow, flow will be shunted readily from the obstructed side to the non-obstructed side. And therefore, if you're looking, for example, at your peak velocity through the aortic valve, it will tend to underestimate any stenosis that might be there, because usually the ventricle is not as preloaded as it would be in the postnatal heart, where the capacity for shunting is much reduced. So interpretation is quite difficult, I think, isn't it, Josh?
Yeah.
These?
We can see the pulmonary valve moving normally there and a nice pulmonary artery, and I had the 3-vessel trachea view. I guess it's functional that we also, not in our screening examinations, but in our regular, in our fetal echocardiograms, we're looking at flow with color as well. Mm-hmm. And I will zoom up again on the heart and see how the color looks here. Now this is kind of, when I'm scanning, I usually like the scale a little bit lower on the color. So I'm going to take it down a little bit here. And particularly when we're looking for the pulmonary veins, it has to be lower than this. We just changed the appearance. If you look at the right-hand part of the screen here, we've got the scale, and you notice we added some green. I'm going to make that go away and bring it back. That's the variance scale looking for turbulence, and I usually like that on as my standard setting in looking at the heart, because I want to know about significant turbulence that's present. This is I'm going to try to look at the interventricular septum. There we go. So we're not seeing anything suggesting ventricular septal defect. I'm sweeping across the septum up and down to look for any flow. And we can see normal flow across the foramina vale. Right there, that flash of red is flow across the foramina vale. And then I'm going to bring the scale down even a little bit more. I actually put it in the mid-20s to look for pulmonary veins. So we should see, if we have the right scale, we should start to get some flow in the pulmonary veins. In this position, the left pulmonary veins will show up in blue. There we go. There's a left pulmonary vein. Just change the gain. Oh yeah, the cone flow gain is kind of low. So that shows up in blue, and then right pulmonary veins are going to show up in red. Just got a little bit of it. Sometimes we can come over the shoulder to see that from the other side. That's not going to work here. Gain's up to 56. I'm going to increase the gain a little more. too much gain. Just saw the red of the pulmonary vein, which is, color is going to be affected just like the grayscale by bones. So if the grayscale doesn't look good, the color isn't going to look good either. So I'm trying to get around the various bones. Let's try it again. Also try to keep that color box as small as you can practically. That'll improve the quality of the image and the speed of the frame rate. We want to keep the frame rate high. You can see we're at frame rate of 41 frames per second here. If that gets too low, it just looks like an old-time movie that's not flashing at the right speed. So if I, let's see, I'll take the zoom off. And what can I do to artifactually make that look bad? I could reduce I can make the depth, trying to get a really low frame rate here. I can make the color box bigger. That's right, that one. Get rid of that. There we go. So now we're down at 10 hertz, and we can see that it just looks like colors flashing on and off. It doesn't look like real time anymore, and that's just an artifact of too low a frame rate. I think I'm running out of time. Are there questions from the audience, Selena, that I can answer?
Would anyone like to? We have about 2 minutes left on the practical scanning since we started a little late. Would anyone like to see anything? You'll have to shout out because it's still dark in here. No, I think people are happy. It shows how difficult it is to do a live functional demonstration, and this is real life, isn't it? So if you are doing this in your practice, you'll have to make sure you have enough time and slack in your daily work schedule to be able to get the fetus into the quietest and most comfortable position so that you can make good and reproducible measurements.
Just showing the aortic arch. Another
can we see an assessment of contractility?
I'm sorry.
Josh, would you be able to just show contractility for us? You mean long axis or minor axis contractility?
For our practice, we assess contractility subjectively. I don't routinely do M mode in fetuses. For those who want to do M mode, to look at contractility, you want to get a long axis view of the heart like this, and then again I'll zoom it up, and I got to remember where the M mode button is here. Where's the M mode button? The one that says, the big button that says M mode, of course. And we want to be really in a 4-chamber view just below the valves. And then we can, maybe a little more gain. Will help the way the M mode looks. So then there are packages that are built into all the systems that will allow you to look at things like fractional shortening and all with the M mode. Any other questions from outside there?
Anybody else? Thank you very much, Josh. I think we can go on to the oral presentations.
Thank you for our model.